So moving on to our next question. The next couple are going to be about diagnostic stuff, and then we're going to talk about what the different pathologies that you can come across are. So we have a 32-year-old lady. She presents with a 10-month history of right upper quadrant pain that radiates around her back. It usually comes on after eating, and it's exacerbated by fatty foods. On examination, she's actually pretty well. Vital and signs are all stable. She doesn't have a temperature, and her abdomen is soft and non-tender throughout. Her blood results, including an FBC, LFTs, and an amylase, are all normal. What is the most likely diagnosis? Good. Okay, so a lot of you have this. So to talk about why, it's biliary colic. And I'm going to talk through what all the different ones are in a second when we come on to the next slide. So biliary colic, the history here is a chronic, because it's 10 months, history of intermittent pain. She's systemically well, and that's the key here that makes this biliary colic over, say, acute cholecystitis or cholangitis. Usually the reason why you get the pain after fatty foods is postprandially. You have the duodenum releases cholecystectomy and the gallbladder then contracts. And the reason why you get the pain is that the gallbladder contracts down on the stones within it, or sometimes you transiently, they will get impacted at the neck. And again, it's the contraction on that causing the pain. Just to note, biliary colic is a bit of a misnomer. It's not a colic like renal colic. It's a fairly consistent pain once it's there. It then goes away, so it has this bounce history, but it's not a colic in that the actual pain itself will be described as like a cramping that comes and goes that you might have with like a kidney stone. It's a constant pain that they'll describe when they're sitting there in the A&E department with it. So acute cholecystitis, if a stone becomes impacted in the gallbladder, sort of along the cystic duct, the gallbladder can then become irritated by retaining all that concentrated bile, and it becomes inflamed. Therefore, you get a patient who's systemically unwell. So they might have a fever, and key, they would also have a raised white cell count. So those are the things that point you towards an acute cholecystitis. In ascending cholangitis, the stone has moved a little bit further along, and this is an infection of the common bile duct. So usually this is because a stone has passed into the duct, blocked it, and then up through the rest of the biliary system, you have a bacterial infection. So the classic description is a Charcot's triad, and it's only present in about a third of the cases. So if they don't have all three, it doesn't rule it out, but it's a combination of fever, jaundice, and right upper quadrant pain. So here we have a lady, she's got normal observations and blood results, and so that's why it's not the correct diagnosis here. Acute pancreatitis. So the classical description of an acute pancreatitis is epigastric pain that radiates through to the back. Yes, in a more real life situation, sometimes people are a bit vague about where their pain is. So you should be considering biliary pathology in your differentials for pancreatitis and vice versa. However, the patient is usually really very unwell with pancreatitis, and you would see a raised amylase, which is not present here. Cholangiocarcinoma. So this usually you see in a painless progressive jaundice and a palpable gallbladder. There's something called Courvoisier's law, which I'll talk about later on in the talk. And also you might find that there's systemic features like weight loss and lethargy with that, as you see with any cancer. So talking through the kind of main things that you're going to come across in biliary pathologies. Biliary anatomy is key here. So I know all of your anatomy is key, but be able to draw this system by heart, and it will really help you out because all of it just depends on the location. So to walk you through the diagram, I'm sure you know you have your right and your left hepatic duct. This forms into the common hepatic duct, and then it's not very long on this particular diagram, so apologies for that. But the cystic duct comes off of the gallbladder. When that joins with the common hepatic duct, you end up with the common bile duct. And then it's going to join the pancreatic duct later on, and together they're going to open into the second part of the duodenum and the sphincter of Oddi surrounding it. I think sometimes the terminology can get a little bit confusing. Just to note, the ampulla ovata is when you have that combined common bile duct and the pancreatic duct together in the bit just before this opening. It's of a very variable length, but often fairly small. The sphincter of Oddi is the muscular sphincter around it that can close, just to differentiate between the two. So the reason why this matters is that talking through our different pathologies is the stone moving along in a progressive way. So we've talked about biliary colic, how it is sitting in that actual gallbladder, or maybe transiently becoming impacted at the neck, and when the contraction happens on it, causes you the pain. But then the stone floats off again and it's all right. So you don't see any obstruction. The gallbladder itself doesn't become inflamed and infected, so you won't see the white cell count and all the rest of it comes with the other pathologies. What happens if it moves slightly out of the gallbladder and becomes stuck? That's then your acute cholecystitis. So this is where the stone has got stuck in that cystic duct. It hasn't reached the common bile duct yet, but as a result, you have got an obstruction there that's backed up all of the bile into the gallbladder. And that's really irritated it and inflamed it. So you have a raised white cell count and you have a fever with it. So that's when you have acute cholecystitis suddenly, itis meaning inflammation. But as you can see, if it's still in the cystic duct, there's a lot of drainage still happening. The common bile duct is still patent, it's still draining the liver. So this is why you don't suddenly see an obstructive jaundice picture that's very acute and florid sitting in front of you. By contrast, if that stone moves along a little bit and becomes stuck in the common bile duct, you can see then we have a pretty obstructed system. And as a result, that inflammation can very quickly ascend up into the liver sometimes with those hepatic ducts, and you get a superimposed bacterial infection on top of that. E. coli is the most common culprit most of the time. And the reason why that's because you can see if we've blocked it off, then we are going to get deranged LFTs because we have an obstructed system here. You will have a fever and be systemically unwell. You will have a raised white cell count. And don't underestimate ascending cholangitis patients because they may be a 40-year-old female. These patients will compensate very well for a considerable amount of time, but ascending cholangitis people can deteriorate very quickly and they need to be taken seriously. You need to go into your ATE and your septic 6, but we'll come on to management a little bit later. So bearing this in mind, we're then going to move on to questions again surrounding diagnosis and see if that's been assimilated. So we have a 58-year-old obese lady now, and she's got acute onset abdominal pain. She's febrile and she's tachycardic. On examination, she's clinically jaundiced and she's tender in the right upper quadrant with a positive Murphy sign. What is the most likely diagnosis? Okay, good. So we'll just talk through it for those of you who didn't pick C as to why. So here we have a systemically unwell patient and she's displaying Charcot's triad. So she has a fever, she has jaundice, and she has right upper quadrant pain. So that's those three. This is what points you to ascending cholangitis and not to acute cholecystitis, is that she has all three. You wouldn't have the clinically jaundice appearance in acute cholecystitis because it's still in that cystic duct. It hasn't dropped into the common bile duct yet. So the cholangitis we've talked about is an infection of the common bile duct and maybe also the hepatic ducts from that obstructing stone. This is the stagnant bile is what is going to progress you into that bacterial infection. And the other factors that are pointing towards biliary pathology are the things that we've talked about in the past. She's female, she's over 40, she's obese, and all of these are risk factors for gallstones. By contrast, if this was biliary colic, we would have a systemically well person, and it would be a chronic intermittent pain history. She would not have the jaundice as well. The acute cholecystitis, you differentiate from the biliary colic by the presence of a leukocytosis and a fever. So we know that she is clinically unwell, but when you add in the jaundice is why we then point towards ascending cholangitis and not simply acute cholecystitis. A pancreatic carcinoma. So if you remember that anatomy again that we've just talked about, anything can obstruct that common bile duct or the other ducts. It doesn't just have to be within the lumen of the bile duct. It can be an extrinsic compression. So ahead of the pancreas, a tumor can definitely obstruct the common bile duct and cause jaundice, but that's going to grow very insidiously. So you're going to have a progressive, painless onset of that jaundice, and she wouldn't have a fever like you see here. With renal colic, don't forget this is a differential. That's why I wanted to put it in. If someone says right upper quadrant pain, there's also renal colic. It might actually be more tender around the back when you go to examine them. So don't always jump towards this has to be biliary pathology. But it would not explain the jaundice that we see here. And usually you'd expect the history to be of urge, frequency, hematuria, the typical stone symptoms. So moving on to the next one, we're going to talk a little bit about investigations after this. So we have a 45-year-old lady. She's got fever and abdominal pain. On examination, she's sweaty, but she's not jaundiced. She's tender in the right hypochondrium and the epigastric region, and she's Murphy sign positive. She's pyrexial, but otherwise her obs are stable. Her LFTs and her lipase are normal. What is the best investigation that you would book for her now if you're the one seeing her to confirm your diagnosis? Great. Okay, so again, most of you picking the correct answer. So let's talk a little bit about why. So an abdominal ultrasound is, I hope that you've picked up this picture as acute cholecystitis. That's because she's got right upper quadrant pain. She's got a leukocytosis, but she's not jaundiced. So we're not worried about ascending cholangitis at this point. An abdominal ultrasound is both sensitive and specific for gallstones. And if the stones are present, then what you would see is wall inflammation or maybe some stranding around the area. If you have complications of acute cholecystitis, for example, raised liver enzymes, and you are worried that maybe there's an additional stone that has dropped into that bile duct, that's when you'd look into further tests like an MRCP. To look out for that concurrent common bile duct stone, but that's not your first line one. You're going to go for an ultrasound. It's quick, it's cheap, it's easy. A CT pancreatic series. So if you were suspecting pancreatitis, this would be appropriate. So usually when you're a clinician, you should be thinking when you're requesting an investigation, is this going to rule something in, rule something out, or is it going to change my management? And those are really the three reasons that you're going to be justifying, which will be to your radiologist colleague. And if you don't actually, if you can't quite characterize in your head why you want this particular investigation, then we need to have a think about actually, should we be doing this? Because otherwise it's an academic point that could be doing harm to our patient. So this would be useful in ruling out a diagnosis if you were not sure if this epigastric pain was pancreatitis perhaps. But given her lipase, which is a very sensitive test for, more so than amylase for pancreatitis is normal, I think we can rule that out and say we don't want to CT a pancreatic series. So an abdominal X-ray. Acute cholecystitis is not an indication for an abdominal X-ray, but if you were suspecting a bowel obstruction or a perforation, so maybe a perforated duodenal ulcer, This or an erect chest X-ray could rule out pneumoperitoneum or distended bowel loops. So that one is a fairly quick one to rule out some differentials, but the question here is to confirm the diagnosis, and that's not what we think this is. We don't think it's a perforated viscous. We think it's a cholecystitis. So troponin. I wanted to put this in because although in medical school, I know we learn everything in systems, and that is a useful way to learn it, your cardiac, your respiratory. Remember, in a human, these clinically defined areas are actually all very close together, and they can cause lots of different pain. So if someone says epigastric pain to you, don't just think through your abdominal differentials. Do think, could this be an MI? Because actually it's easy to get an ECG and to request a troponin on your bloods to rule that out. So this is more if you're the A&E doctor and you're trying to triage what you think this is, rather than you're the surgical anaesthetist who's been bleeped to a confirmed cholecystitis or something similar. So here, the reason why I'm not suspecting an MI, although you should consider it, is that she's hemodynamically stable and she's Murphy sign positive. So that's tenderness when you push the side of your hand into the right side of the abdomen when they breathe in. And the reason why they say ow is that unfortunately it's a bit of a mean test, because what you've done is taken their enlarged inflamed gallbladder, and as they breathed in, it's smacked into your hand. So they don't thank you for that, but it is, if that's positive, it's a good way to point towards that this is actually, we've got a biliary pathology here. Again, so the troponin here would be to rule out something, but here we've asked to confirm the diagnosis. So a non-contrast CT scan. So a CT has a reasonable sensitivity for acute cholecystitis, but an abdominal ultrasound is actually more specific, and it's first line. So if you get a negative CT, it does not rule out the presence of gallstones. And if you suspected, say, a perforated viscous, and that's why you wanted a CT, the CT you'd need is one with contrast, because that's what allows us to see the bowel better and to help us see if there is any perforation there. So in terms of your investigations, I encourage you, there's usually a variation in years here. But if you're earlier on, or even if you're later on, get used to structuring things. So rather than just thinking of all the different investigations that you want and listing them off, not a list, how are you going to structure them? Now, I don't mind how you do it. For me personally, I find it easier in my head to think through all the investigations I can do at the bedside. Bloods I then kind of count as a little bit away from the patient, and then my special imaging. So if someone says, what investigations do you want for this patient in exam? I say, well, bedside test I do is this, then I do these bloods, and my specialist imaging is this. And it looks neater. So at the bedside, we can do an ECG, we can do an erect chest ray and abdominal X-ray. We've talked about why we might want these two things. An ABG is going to be useful if you're considering pancreatitis, because it's part of your Glasgow score. And a VBG, if you're not worried about that, is going to be useful because it'll have a lactate on it if you're worried about a septic picture. And also it's going to have a blood glucose. Again, in pancreatitis, that can sometimes be useful. Or simply if your patient is diabetic, when they're ill, their sugars tend to go up. So you might want to know what that is. In terms of your bloods, FBC, that's useful to know because I want to look at the white cell count. If it's predominantly a neutrophilia is what I'd be expecting with this. Also, HB is good to see if there's any sort of chronic iron deficiency anemia that might point towards maybe a cancer, or if there's any, say, hemorrhagic pancreatitis, we want to know what that is. And amylase is for pancreatitis. You will read that lipase is more specific. It is. But in a lot of hospitals, largely due to cost, I think, but I'm not 100% clear on that, the test that will be available to you is an amylase. So that's why I've put that on there. You may also want a calcium. Usually you have to ask for this specifically. And that's again in something like pancreatitis, you end up with a drop in calcium. So you'd want to know what that is. Usernese, you need to rule out if someone's been really unwell or been vomiting or just in too much pain, they may not have drunk anything for a while. So you want to A, know what the kidneys are doing, but B, see if there's an AKI, and then it's going to guide your fluid resuscitation from then. A clotting is going to be good and a group and save because you've got to think a little bit down the line. So if you're that surgical F1 or SHO who's seeing them, you want to get everything teed up that when your seniors see them, stuff can happen quickly because that's the best thing for the patient. So if anyone was going to need either an ERCP or you would need a clotting, and if you were considering any kind of surgery on that admission, you'd also want a group and save. So it's useful when you're taking bloods just to add those on. So specialist imaging, we've talked about. The most useful is going to be your abdominal ultrasound, and then others we can think about are CT, either AP with contrast, pancreatic series. An MRCP is an MRI of your biliary pathology, and that's diagnostic. An ERCP, again, so you can visualize the biliary system, but also it gives you the treatment benefit. But there are risks associated with that. So we'll come on to talk about that in a second, about when you might want which one. So that's quite a lot. I've tried to summarize it in a cheat sheet. You can make your own one if you don't like my one. But I think all of these, it's a lot of names that all sound a bit similar, have roughly similar symptoms, and it can get quite confusing. So I think it's a lot easier if you just lay it out in a table like this. So we're going to remember that biliary pathology in our head again. I've laid these out in terms of the stone moving along that anatomical system and it causing a problem. So biliary colic, still in the gallbladder. Acute cholecystitis, moved a little bit, stuck in the cystic duct. Colidocolithiasis, fancier word, is a way of saying that there is a gallstone that is in the common bile duct, but unlike an ascending cholangitis, you do have inflammation, but you don't have the superimposed bacterial infection on top. So if you see that, they're more well, because usually they only have a partial obstruction. So your LFT pattern is only mildly raised. It's not sort of completely deranged like you might see in ascending cholangitis. We've talked about that your bloods on your acute cholecystitis are going to have a leukocytosis, unlike in your biliary colic. They will definitely be raised in ascending cholangitis because that person is unwell and may become septic very, very quickly. In terms of your imaging, abdominal ultrasound, we've said, is first line. If you see in your ultrasound that the common bile duct is dilated, that is when you might want to think, oh dear, do we also have a stone in the common bile duct with either colidocolithiasis or ascending cholangitis actually is the correct diagnosis. In order to look for that, you need an MRCP, which is an MRI to look for that stone. Some argue that an ERCP means that if you saw the stone, you can take it out at the same time. That's a scope that's going to go down into the biliary system, and you can either sort of, it's got little grabbers or it's got a basketing technique. Problem is, ERCP, you might cause a perforation, or you can cause a pancreatitis. It's one of the causes of them. So this is when to chat to your seniors, because they may want to actually go for an MRCP to look to confirm that that is the diagnosis before we go for an ERCP. In terms of your definitive treatment, if you have biliary colic, the gallstones need to come out. The way we do that is we take out the gallbladder, but they're not super unwell right now. It can wait. It can be an elective procedure in 3 months' time when they're well. We can plan, we can work them up for it. That's all fine. Acute cholecystitis, you need an emergency cholecystectomy to reduce the morbidity and mortality that comes with prolonging waiting for that procedure. They can't wait, unlike the biliary colic. Colidocolithiasis and for ascending cholangitis, you need an ERCP, and it is needed urgently in ascending cholangitis. That is a sick patient. So these, I hope that helps to clarify it a little bit more with all these different names. So now we're going to come on to talk a little bit more about the complications you can get subsequently from gallstone disease. So our next SBA is a 63-year-old gentleman. He's admitted with severe generalized abdominal pain. He's vomited 5 times and he's not opened his bowels or passed wind for 2 days. He's on the waiting list for an elective cholecystectomy, but is otherwise usually fit and well. He's tachycardic, he's febrile, his abdomen is quite distended. What is the most likely complication that's occurred here from his gallstone disease? Okay, that's really good. I wasn't sure how many, not everyone's always heard of Gallstone Alias. So what I'm hoping that people have picked up on is that what I've described here is a small bowel obstruction picture. And if this is secondary to a gallstone, it's what we call Gallstone Alias. Unfortunately, another misnomer here. So Alias usually means in the context of the paralyzed autonomic nervous system that's moving in your gut to keep stuff moving along in that normal peristaltic way. Here, that's not what's happened. This is a mechanical obstruction. It's not a paralytic alias, despite the name. So what's happened is one of your gallstones, it's a rare, but it's a very severe complication of gallstone disease. It's usually in older patients with slightly more friable tissues. Is that a gallstone passes into the intestinal system via a biliary enteric fistula, and then it causes an obstruction distally. So what happens usually is it travels for a bit along the gut because the lumen of the small bowel is bigger than it. And then the bit where your small bowel narrows, which is usually at the ileocecal valve, that's where it's most likely to get stuck. Now, when this happens, the way that we treat it is that you need to milk the gallstone back up a bit. You don't take it out at the site where it's been dislodged. So you take it out, it's usually maybe 60 centimeters or so, but you milk it proximally. You take it out for a small little cut called an enterotomy. You sew that back up. And in this acute setting, you do not mess around with the gallbladder. You make sure that you just deal with that one stone that's causing the problem, and you will take out the gallbladder at a later date. You do not do anything with it on that admission. If you do a CT, you may also see some air in the biliary system from that. It's just one to have a think about. I actually had a patient 2 weeks ago come in with this. Morizi syndrome. So I wanted to put this in because it's not that commonly examined, but it is something you may well come across in your reading, and it's certainly relevant clinically. So this is one of the times where a gallstone has become impacted in the infundibulum of the gallbladder, or Hartmann's pouch is the other name, or the cystic duct. However, it manages to compress the common bile duct. So if you look at that anatomy, the gallbladder is actually pretty close to your common bile duct. And depending on your own personal anatomy, it may be very close. So what can happen is if the stone is big enough, it can extrinsically, a bit like that head of the pancreas tumor, compress that common bile duct and then lead to jaundice. So that's why it's not the correct answer here. It's described that he's not got jaundice. It's not what we've talked about. But it is one thing to think about if you've got a cholecystitis picture, but then also extreme jaundice with it. There's a second type where then the stone can erode through into it, but it's just one to have, again, a think in the back of your mind. So this one, the key bit is that your obstruction is not intrinsically within the lumen, it is extrinsically, but from the gallstone. So gallstone pancreatitis, again, thinking of that anatomy in that first slide, if that gallstone becomes blocked at the sphincter of Oddi, what's going to happen to the pancreas? There's a lot of digestive enzymes that are all trying to get out, and they're going to go back up. Great digestive enzymes if they're going to digest your food in your gut. Really not so great if they start auto-lysing your own pancreas and causing you pancreatitis. So it's why they're one of the most common causes. So usually then in this, what you would expect from a sort of case vignette point of view is an epigastric pain, so it would describe the pancreatitis pain and not absolute constipation, which is what's being alluded to here. So Colidocolithiasis, we've talked that this is gallstones in the common bile duct, but it's got proximal inflammation, but not the full-on fulminant acute cholangitis, but it can progress to that very quickly. Again, so you'd be looking for right upper quadrant pain, jaundice, and that's not the combination that's been described here. So if questions don't give you all the information you want, Each line will probably have a reason that it's in there. So try and read each one and just take the clues that it's trying to point towards from that. And finally, acute cholecystitis, again, probably the most common complication of gallstone disease when the biliary colic has progressed that the stone is in a cystic duct, backed up the system and irritated it. I know this is repetitive, but it's also how we learn. So you would be looking for a fever, a leukocytosis, and it would not explain here the absolute constipation. This is what's implying a bowel obstruction, and the only option that's going to explain that is B. So complications of gallstones, like we've listed before, acute cholecystitis, Colidocolithiasis, so when it drops into the common bile duct, cholangitis, gallstone pancreatitis, Gallstone Alias, and Gallstone adenocarcinoma. So most things that are risk factors for cancers is if there's anything with chronic irritation in there, obviously that means cells always have to repair lots, and if that goes wrong is when you're going to get a cancer. So onto our next case vignette, we're going to start to think a little bit more about treatments. So now we have a 35-year-old lady. She's presented with right upper quadrant pain. She's febrile, but otherwise her vital observations are normal. Her bloods do show a leukocytosis, and her liver function tests, however, including her bilirubin, are normal. An abdominal ultrasound reveals multiple gallstones in a very thick-walled gallbladder. The bile duct is, however, non-dilated. Intravenous antibiotics are started. What is your next best course of action? Okay, so I think depending on which year you're at, you'll have talked about treatment less or more. So let's go through it. So the correct answer was a laparoscopic cholecystectomy on this admission, so less than 72 hours. And the reason why, what I'm hoping is that you picked up that this patient has acute cholecystitis. And so we need definitive treatment after we've done the initial bits with fluids and antibiotics. The reason why this is cholecystitis is because she doesn't have jaundice, her bilirubin is normal, and she doesn't have a dilated CVD, so I'm not worried about a stone somewhere else in her system. If we were to wait and let it settle, then this is going to increase the time to her surgery, and this is going to increase her perioperative morbidity and mortality. So we need to have definitive treatment, ideally on this admission. We usually use laparoscopic methods if we can, and this is because they reduce post-op complication risks and recovery time for the patient, and cosmetically they are nicer. If you are attached to placements, you may see that actually people who have acute cholecystitis are being treated with antibiotics and they're going home. This is being practically done because particularly with COVID, there's been some issues with doing hot coles. But even so, those patients going home, they're not coming back in 3 months' time. They're coming back within 2 weeks to have that gallbladder out. The one that can wait for 3 months' time is your simple biliary colic, not caused you a problem. So in this situation, you do want to be taking that out very quickly. So an open cholecystectomy, it is a possibility should laparoscopic options be contraindicated, but if at all possible, we should be doing this laparoscopically for the patient. So the reasons when laparoscopic may be contraindicated is if the patient was, say, frankly peritonitic or she had a hemodynamic compromise. It should be noted as well, laparoscopic surgery is technically more challenging. So you're going to need a surgeon with that skill set as well. And also when you're consenting, you do always consent for a laparoscopic conversion to open, but if at all possible, laparoscopic, even though this is an emergency surgery. An emergency laparotomy. So this is done when we're suspecting an acute viscous perforation. So it's not the appropriate thing. That's going to leave them, it's a very big surgery. It's going to leave them with a very big scar, and it's probably wholly unnecessary. A percutaneous cholecystostomy tube. So for those of you that maybe haven't seen these before, don't be particularly, I remember when I was like first on the wards as a third year medical student, and then you hit some surgical one and everyone's got different lines and stomas and stuff coming out of him, and it's a little bit intimidating, and people just kind of say, oh, go examine this patient, and you sort of go with a friend and tentatively feel around all their various different tubes and hope they don't say ow and then kind of run away. Maybe that's changed now, but do, if you're on your surgical firms, don't avoid these people. Go and have a look and familiarize yourself with all the different drains. So what you'll see in this one, what's happened here is if a surgical risk is far too high, so for example, a general anesthetic they can't have, or they're critically unwell, then what we can do is, rather than removing the biliary system as an operation, you can decompress the biliary system from a tube that is going to be placed in the very first part of the gallbladder, so not where it's connecting to the cystic duct. At the body on the other side, there's a tube that's placed by IR, or interventional radiology. So if you see a tube that's coming out of the right-hand side and it's got bile contents in it, that's probably what that is. And sometimes as well, you don't even spot it. It's like around the back, or the patient's lying on the bag or something like that. So that's what I'm saying, go see these patients, do fully expose them, ask the permission, but do get used to seeing these things so they don't throw you. So for example, the last of my patients that we took for this, it was because he was well into his 90s, he was critically unwell, he had a very gangrenous gallbladder, in fact, and it just wouldn't have been appropriate to give him a general anesthetic. But if you can, a cystectomy is better than a cystostomy because it has superior outcomes. So I hope that's cleared that one up a little bit more. In terms of broad principles of treatment of biliary disease, again, structure. It will just help you to think about where you might go with it. So there's two ways you can structure treatments for any surgical pathology, really. Either you can say, you know, if someone asks you, you can go, oh, there was conservative or there's surgical methods, or you can say initial or definitive treatment. I don't really mind which one you use. Certain things you may actually want to switch between them. So here, the conservative treatments would be your IV fluids, your antibiotics, making sure you do your A to E. You may need to do a septic 6 if it's ascending cholangitis, getting your seniors involved early if you're worried. The surgical management is going to be the definitive management. So you can also then label all these septic 6, A, B, C, D as your initial resuscitation and treatment. Your surgical, your definitive treatment is going to be when we take that gallbladder out. So the emergency cholecystectomy that we've just talked about. It helps, if you will have the slide goes up, it goes up on YouTube. So you have that cheat sheet. We talked about Ercp being the treatment for ascending cholangitis, because you can go and you can grab the stone that's causing the problem. But again, just thinking through things as a structured. If you have written lots of lists in your notes, go back to them and then look at the list and think, is there a better way I can structure this? Because then even if you can, you know, if it was differentials, even if you can only think of 2 for a couple of them, then you instantly sound more like you know what you're doing if you can structure it to your bosses. And it just helps you learn stuff when you're very tired and remember it. So the next one, we're going to talk still about some post-operative complications that you can get. So we have a 46-year-old gentleman, and he's had the laparoscopic cholecystectomy that we ideally want to do for these patients, and he had it 2 days ago. The operation was technically difficult, and a biliary drain was left in situ. Today, he has increasing amounts of abdominal pain, and he's required regular opiate analgesia. He's febrile and he's tachycardic, and the drain appears to have bile in it. His blood shows stable hemoglobin, but deranged liver function tests. What is the most likely post-op complication that's occurred? Okay, so almost a bit of a split. The majority of you do have it right. It is a bile leak. So so this is again why you familiarize yourself with patients on the ward and stuff, because it's a lot easier than picturing in these case vignette situations. So when a drain has been left post-operatively, that's not the same as the cholecystostomy tube that we just talked about. What's happened there is a surgical drain has been left in the site just for any ooze or anything that might have occurred to drain away. He should have had his gallbladder out because that's the operation he had. So the reason why this is most likely a bile leak is that if you've got, it sounds like it's bile in the drain, and he's got abnormal LFTs. So what's probably happened is that the clips on the cystic duct remnant may have slipped, or there is a missed distal common bile duct stone that's now causing an obstruction, and it's built up, and it's blown out higher up. The other thing that can sometimes have occurred to cause this is an iatrogenic injury to the common hepatic or bile duct. So we may have done it. An ERCP or an endoscopic retrograde cholangiopancreatography can identify the site of the leak and allow simultaneous intervention with a temporary stent to allow biliary drainage. An abscess. So again, trying to think about structuring complications, there's two main ways to do it. If you're talking about a specific operation, then it can be useful to do general operative complications and the surgery specific ones. So I'm going to talk about that in a second. The other way you can structure it if you prefer, and it works better for some stuff, is to have your immediate, so in the hours after surgery, your early, so in the few days after surgery, like he is, or your late complications. An abscess is a late complication. A 2-day time frame does not make this very likely. It just hasn't had the time to build up, but he would be at risk at this later on because blood mixed with any kind of bacteria is a sitting duck for an abscess. It's just not the correct time frame here. Abdominal bleeding. So his hemoglobin is stable, but in an acute bleed, don't be fooled by normal hemoglobin. It can initially be normal until time means that a dilutional effect occurs and then you see the HB suddenly drop. But the fact that the drain only is described to have bile in it, it doesn't describe any blood in it, it makes this a less likely diagnosis. So post-cholecystectomy syndrome, again, this is a late complication that's going to occur. This is a syndrome where you have recurring abdominal pain and reflux symptoms after having had your gallbladder out. The patient would be clinically stable, which they're not here, and it can present months or even years after the initial surgery. So paralytic alias, again, valid post-operative complication, and he has got one risk factor for it. He's had opiate analgesia, which can give you a paralytic alias, but it would present with absolute constipation, maybe vomiting, and that's not what's being described here. It's also more common after surgeries where you've handled the bowel for a long period of time. So if this was an emergency laparotomy for repair of a perforated viscus, that's your risk factor more for paralytic alias. Here, a laparoscopic cholecystectomy doesn't quite fit the picture as well. So post-operative complications. Here I've divided it because we are talking about a cholecystectomy, about general post-operative complications, and then the biliary surgery specific ones. So we've just talked in that case about these surgery specific ones. You can have a missed CBD stone, you can have a bile leak, which can be a slipped clip, iatrogenic injury, or a stump leak, and you can have post-cholecystectomy syndrome. Your general operative complications, bleeding, infection, abscess, a DVT, PE, or you can injure any other stuff that's around it, which in this situation would be bowel. And these are all things that you're going to have to counsel them about when you get to a point in your career when you're doing consent. So on to the next SBA. So we have now an 82-year-old man, and he's presented with progressive painless jaundice, pruritus, and unintentional 3-stone weight loss. On examination, he's afebrile and clinically well. He also has an enlarged liver. Cholangiocarcinoma carcinoma is what you're suspecting. What is the following is a risk factor for bile duct cancers? Okay. Yeah, so again, majority, well done, have it right. It is inflammatory bowel disease. So IBD is associated with cholangiocarcinoma, and this is also particularly if it's associated with primary sclerosing cholangitis. So in this talk, it's slightly beyond the scope because we're going to talk about surgical biliary pathologies, to talk about all the different causes of liver and biliary pathologies. Is slightly beyond the bounds and is covered in other Quesmed talks. But this is what you'd be looking out for, is if it's got an association that chronic, or if there's been chronic gallstones, then that could also be your risk factor. Talking through the other ones, sometimes some of these are just facts that you have to know, sadly. So von Hipperlindau gene, this is a gene, but it's implicated in clear cell renal cell carcinoma. It's nothing to do with bile duct cancers. Polycystic kidney disease, it's polycystic liver disease, not kidney disease, that's the risk factor, as are congenital hepatic fibrosis and colidocal cysts. This would be more relevant perhaps, so polycystic kidney disease is often then associated with polycystic liver disease. So it could be in that way, but that's much more indirect and it's not what's stated here on the question. Female gender, so when it comes to cholangiocarcinomas, whilst for gallstones themselves, female is the risk factor, male is the risk factor for the cancer of the bile ducts. And aromatic amines, if you see this, this is an occupational risk factor for transitional cell carcinoma of the bladder. So that's what that question is trying to point you towards. So you can get cancers of the gallbladder, the bile ducts, or the head of the pancreas. And all of those can cause you a painless progressive jaundice. And that is Courvoisier's law. Now, I don't think I learned this when I was in medical school, that it is basically if you have jaundice and a palpable gallbladder and it's painless, then jaundice is unlikely to be due to a stone. But I don't think anyone really ever explained to me why. And I find it a lot easier to understand and to remember stuff if I understand why. So I'm going to try and talk you through it now. So if you imagine that you have gallstones, what you're going to have is a gallbladder that's thickened and fibrotic because it's had lots of chronic irritation. It's therefore going to be quite small. And it's usually then what's going to happen is that your obstruction, it's not usually completely complete. There's some tiny bits that can get around it, you know, in the same like overflow diarrhea, there are some little bits that can get around. So some bile is going to end up in your duodenum and the gallbladder can decompress a bit. So you wouldn't have a palpable one because it's small for those reasons that we've just talked about. Or if it does get distended, it's got a fibrotic wall and it doesn't have the capacity to expand into that palpable thing that's being described here. Whereas in a malignancy, what you have is a normal gallbladder. They haven't had chronic gallstones throughout their life. You have a normal wall, and that means it has a capacity to dilate. Therefore, if you obstruct it, whether it be in the gallbladder, the bile ducts, the head of the pancreas, wherever it's being compressed from, it has the capacity to dilate when it's backing up in that system and get bigger and bigger and bigger, so you can palpate it. So I hope that's a little bit clearer. The risk factors up there again, we've talked through. Male, obese, smoker, greater than 50, recurrent stones. Those abbreviations are for primary sclerosing cholangitis, inflammatory bowel disease, cystic fibrosis, and diabetes mellitus, or for congenital abnormalities. Again, if you wanted a way to structure even risk factors, you can do it into modifiable and non-modifiable risk factors. So that's another way. The majority are adenocarcinomas, and 50% of a porcelain gallbladder, so it's when it's become calcified and you can see it on an X-ray, are associated with a gallbladder cancer. So that would be another thing to look for in your case of So moving on then to our final question, I believe. We have a 21-day-old baby that's with jaundice. He was full term, he's a normal birth weight, and he appeared well until recently. The blood results show a conjugated hyperbilirubinemia. What is the most likely diagnosis? Okay, yes, so the answer was D, but there's a bit more of a mixed picture there, so let's go through it. I'm going to talk through the relevant bits surgically with congenital ones, but neonatal jaundice is going to be covered in a pediatric talk. So I'm just cautious of slightly encroaching onto their territory. So here, the reason why it's biliary tracer is because it is a conjugated hyperbilirubinemia. So when we find that someone's got a super high bilirubin, we need to know if it's conjugated or unconjugated, because it essentially means, has it been processed? Is it able to be processed by the liver or not? So here it's conjugated. It is able to be processed in some form. Whereas, so we'll talk through why the other ones give you an unconjugated. But biliary tracer itself, this is when the lumens have failed to obliterate. Your incidence is approximately 1 in 10,000, and usually you may see an association with other congenital malformations, such as intestinal atresia or an imperforate anus. It's surgically treated with the Kasai procedure. I wouldn't worry too much about this, but broadly speaking, what you end up doing is bringing up the small bowel to directly take bile from the liver, to bypass it in that way. You can have a Google if you're interested, but I wouldn't worry too much about it. However, many of these children will go on to need a liver transplant as well. So it's something the parents are going to need careful counselling over. So cystic fibrosis can present with a bile plug in the same way that all of your respiratory secretions in it get stickier, your meconium gets stickier. You can also get your bile get stickier, and you can cause a jaundice if it gets all stuck and it becomes slowed down. Usually, though, your first presentation of a cystic fibrosis would be Meconian Alias in the first place, so it's not that common. It can happen, but what you would look for in a cystic fibrosis situation is having concomitant failure to thrive. So there might be weight loss or just failing to gain in the way that they should. So that's what you're looking for. Otherwise, this was a perfectly happy, healthy baby until recently. Gilbert Syndrome. So this would cause an unconjugated hyperbilirubinemia. It's an autosomal recessive disorder, and you get a defect in the UGT1A1 gene, which, rather than worrying about that gene too much, it impairs bilirubin metabolism. So that's why it's unconjugated. We have the same in Creuker-Najjar syndromes. So both, there's two types, but in both types, you have an unconjugated high bilirubin level in the blood. It's also autosomal recessive, and again, it's an impairment in the bilirubin metabolism. This one is something to be worried about because it can turn into brain damage with toxins building up. Breast milk jaundice, again, it causes an unconjugated hyperbilirubinemia, and it's usually mild. So that's the thing that points away. We're not quite sure why you may get breast milk jaundice. It's possible that something in the breastfeeding temporarily causes an impairment in bilirubin metabolism. But again, the baby's usually quite well, and it's usually after 2 weeks or so. So though that was a whip through of that one. So in terms of congenital biliary abnormalities more broadly, from a surgical point of view, they're going to be relevant because some of the malformations you may encounter if you're doing that cholecystectomy on a 40-year-old lady, there may be a malformation that is very relevant to you to know about as the surgeon, because it's going to affect how you take it out. So biliary tracer. Talking through how the gallbladder system forms, it buds off at the 4th week of pregnancy. You get a hepatic diverticulum that comes off the ventral wall foregut, or the primitive duodenum, and this turns into your liver and your biliary structures. You get a lateral bud that comes off and turns into the cystic duct and to the gallbladder. If you like embryology, usually these things are better watched as a video because it can change and it's all 3D, and it just makes it a little bit easier to visualize. So in biliary atresia, it's a congenital obliteration of the ducts. It's 1 in 10,000, and it's usually got other congenital abnormalities. A colidocal cyst. So this is a cystic dilation of the main bile ducts, and it's about 1 in 200,000, so it's much rarer, but of note, it's about 1 in 1,000 if you're Japanese. So it's more common in Asian descent, and it's something to think about in your head practically when you're clinically seeing people. You may have a duplication of the gallbladder. That's about 1 in 5,000. You may have an absence of the cystic duct. So the gallbladder here is going to open directly onto the side of the CVD. So again, very relevant if you're going to get into that as a surgeon and you're trying to look for where you're going to put your clips. Gallbladder agenesis or a congenital absence, 1 in 10,000. And again, there's often other congenital abnormalities with this. So that concludes the talk. I hope that was informative for you guys. I'm happy to take any questions. I'm just going to stop sharing my screen.
Thank you very much, Dr. Edison. That was such a well-explained talk. There are some questions which were popped into the chat at some point during the session. So we have one question from Mira Ahmed, who asks, is it biliary stasis in ascending cholangitis that predisposes it to infection?
Yes, it is. Anything that's stagnant, you have a stagnant pool of bile, and usually we have E. coli that is what's going to cause you the problem. That's exactly it.
And we have a question from Miranda Layton, who's asking, is that Wrigley's triad? I think that was in relation to the Gallstone Alias question.
So the triads that are relevant here, you have Charcot's triad with the right upper quadrant pain,